recording now. Hopefully everybody can hear me very well. Please use the chat window if you can't hear, or if you want to give some questions. We will answer the question as possible after the webinar, not in between. The chat window can be reached if you go with the mouse to the top of the screen and click on the little chat icon there. The webinar will be recorded and, well, it takes maybe some days, but then it will be available through our KaVo.com website, and you can hear and see the whole content of the webinar. This is for the end, and I actually will now hand over to Professor Schulze so he can start. Change you to presenter.
Okay.
Okay.
So, I hope you can hear me.
Well, I can do.
Okay. So now I will share my desktop, and you will immediately see, I hope, all of you, what we are talking about today. And it's just a couple of cases I will present to you with some ideas what you can do or what you can avoid in implant diagnostics. And it's just let's say quintessence of some years of work. I started in let's say 2000 with CBCT evaluation, so you can imagine that I've seen a lot of cases with regard to implant planning. So I think I made it very simple for today. So what we're gonna talk about is that we watch out some simple planning issues, like how we have to prepare something before we make a CBCT for implant planning. Next point would be to respect some anatomic variations we can see in a patient, so that you have to look for, let's say, some distinct landmarks which can be a problem or result into some problems when you make the evaluation of the data sets. We will check out some physiologic changes which we can see in the bone, which are of some value for you. That means not only the, let's say, strict measurements, but also changes after, let's say, extraction of teeth, what you can see in CBCT data sets. We will have a look on some pathologic patterns and some problems which can occur in the bone. And finally, we check out for two, let's say, misled cases with regard, one to implant placement and the second one to a postoperative problem which occurred, which was very severe, and I think which dramatically underlines the need for a proper imaging with regard to external sinus augmentation. Okay, let's start with some simple issues. First of all, we have to select the proper patient. Here, maybe you say, okay, everybody who needs to get some implants can be put into a CBCT device, and I can acquire a volume. I can tell you that not every patient is really suitable for CBCT examination, and we have to look for some precautions prior to the imaging. We have to check out for some removable prostheses, for some jewelry, and especially for hearing aids. Don't forget hearing aids, because they will cause some severe artifacts, especially in the upper jaw. So you can avoid these kind of artifacts when you check out for some hearing aids. Just tell your assistants that they check out for these simple things to avoid any kind of artifacts. And as I said to you, there are some patients which are very, let's say, difficult to acquire. Patients with Parkinson's disease or some tremors. So you have to look for proper fixation in your machine, and there are a lot of differences with regard to headrests or head support. So maybe it is needed that you put on some additional fixation to stabilize the head position. And if it is possible, with your machine, you have to check out for some short exposition time, because the longer the exposure needs, the more time the patient has to move. And we observed that in the past, when the machines needed a long exposition time, we observed more patient movement than today, where we see at least exposition times below 10 seconds or even shorter. And please use, in every case you want to do some implant planning, use a scan guide or a scan splint. And even if you don't want to make navigated implants or computer-aided implant positioning, just check for some very, very easy scan guides with some cylindric reference objects or something like that. I will show you in a minute. So, next point is the selection of some proper field of view or volume of interest. Volume of interest. That means what kind of volume do I need for my planning? Do I need only a small region, let's say of 3 to 4 teeth, or must it be even more than, let's say, about one jaw, upper or lower jaw, or both jaws, if I want to acquire upper and lower jaw for planning in all regions, or shall I acquire the upper jaw with maxillary sinus? I told you this is, from my point of view, conditio sine qua non when you want to prepare something for an external sinus augmentation. And finally, you have to look for some proper exposition and reconstruction parameters. If it is possible, adjust the milliamperes with regard to the patient's constitution. That means more lightweight people, you can use smaller or lesser MA values, and for bigger patients you need at least higher MA values if it is possible to change that. In general, the KV value can be raised to the maximum value if it is possible to change that. So just check that your machine works with the maximum KV values which is available. Reconstruction should generate voxel sizes below or even to 200 microns. So any kind of geometric problem can be avoided with regard to the reconstructed voxel size. So just secure that your voxel size is not larger than 200 microns. Now we see the first case, and what you can see here is that we have some, let's say, metal balls in here, which are not really useful for any kind of reference, because metal balls are round, and a round shape doesn't give you any orientation in the data set where the planned implant axis could be. So we can check out the next image. Is just here the scout view of this image, and we go to the next image. And I hope you can see my arrow. Is that possible? Can you tell me, Mr. Bauer?
Yeah, can be seen.
Okay. Maybe I can enlarge it later on. So what you see here is the transversal cross-section of the right lower jaw, and once again you see here this metal ball, and there is no possibility to figure out any kind of direction of this metal ball. So just avoid the use of any steel balls for reference purposes. On the contrary, we see in the next case that it was the other side, and here we see in addition some figure I will show you again in some minutes, this kind of lingual balcony, which is typical in a lot of patients in the side area, in the molar area. Here again, you all know this problem that you can perform here, any perforation here lingually, so just check out for these kind of balconies. This is a typical physiologic problem in lower jaws. But compare it, just remember these metal balls and compare it to this situation. Here we see a simple reference splint for the left lower jaw. We see a very small volume, just the part of the lower jaw was acquired. And you see that finally in the image I just cropped out this area I need. I made here this marking of the mandibular canal in this on-demand 3D software, and finally the cross-section reference images, these are the blue lines here, are going straight through this cylindrical shape here, and in the next image we can see that here you can really nicely observe the, let's say, planned implant axis, where you can evaluate if this tube or cylinder is useful for further implant placement purposes or not. Okay, so you see a very easy difference between spheres or metal balls and these kind of titanium cylinders, or what you ever want to use for these kind of acquisitions. Okay, next point, anatomic variations. So we've seen this lingual balcony, and I can tell you that most of the anatomic variations occur in the mandible. In the maxilla, we can observe a lot of atrophy. We will check for this in the physiologic changes. So lingual balcony is very common in mandible. Even a lot of variations of the mandibular canal. You can observe different, let's say, lumina of the mandibular canal, 2 or 3 different lumina. A splitting of the mandibular canal can be observed, but these conditions are very rare, so normally or in general you will see only 1 lumen of the mandibular canal. And also a very rare condition is the so-called hourglass shape in the premolar region in the mandible as well. When you make a cross-section of the premolar region, you can observe that the bone gets some kind of hourglass shape. That means in the mid of the bone, the shape is very, very thin, and only the cranial and basal parts of the bone are thicker. And this will lead to, let's say, a figure like a cystic shape in a panoramic image. Maybe you've seen that as well in some images, but this is a very rare condition. So just look for changes in the mandible. And once again, I show you this balcony here in a different patient. Here we have some planning image for the left mandibular part, and you see here in this images you can see that in the molar region again we have some kind of balcony. Just check out for this balcony. So just one simple let's say change of the bone pattern in the lower jaw. Okay, other side as well. Here you can see, very nice. Okay, typical change. Maybe you know, just avoid any kind of planning there. Physiologic changes. Physiologic changes can be seen due to atrophy. You know, in elder patients, we can see a lot of, we can observe a lot of atrophy with regard to the alveolar process, so that only the walls to the, let's say, maxillary sinus are left, or even the mandibular foramen or mental foramen is on the upper side of the lower jaw. So there can be seen a lot of atrophy, even either vertical or horizontal or both altogether. So just check out for atrophy and their consequences for your plans to implant. After extraction of teeth, you can check out for the consolidation of the alveoles. You all know that the bone needs some time to consolidate, and that, let's say after 4 weeks, let's say to 6 weeks, you see first results of consolidation, and that's what we right now will look at in the next few minutes. So please remember that if a consolidation is retarded or prolonged, if there is no real consolidation in an alveole or a root socket, you have to think of any kind of metabolic problems or other issues, maybe an inflammation which is leading to some kind of retardation of this consolidation. So please check for extraction sockets, so if there is a real new bone pattern. So this is just the example for atrophy. We have here upper jaw situation, and this is the what we call it the canine complex. So in most of the patients, even in patients with a lot of atrophy, at least will find some bone in this area where you can take some measurements for implant planning. And what we see here is a typical shape here in the side area, distal area of the upper right jaw, typical horizontal and vertical atrophy, and finally here in this canine region, a typical horizontal atrophy, very thin alveolar process here, and this also is propagated here to the incisor region, and here we are on the other side, on the left-hand side of the upper jaw, and once again, very thin alveolar process, in the canine region, and finally, again, this typical atrophy in the side area. Next patient is the situation after extraction, and I hope that these images are clear for you. I just check if they are in the right order. Okay, here we see a situation some weeks after extraction, and you can see exactly that the second premolar which was extracted, and you can see a very thin, light grayish line of new bone here. Here again, you can see that in the innermost part of the root socket. There's, we have to think about if there is no bone, but it might be. And so finally, maybe the situation is affordable for putting in an implant, but 4 months later, this situation looks like that. So you see a complete reorganization of this pattern. You can just even imagine that there was some kind of extraction, but there is complete consolidation, very good situation for implant insertion. So just remember that you always can take your time, you can wait for the healing of the bone, for reconsolidation of this bony area, and for, let's say, improvement in the structural pattern. Pathologic patterns, which we can observe, you all know root rests, which you have to avoid for putting in implants there. Could be very deteriorating. We have a lot of cemento-osseous changes. I will show you some case of cemento-osseous dysplasia. where you don't know what kind of, let's say, biomechanical characteristics the bone has. So just check out for these cementous or cemento-osseous changes, because they are very common in lower jaw. You can see even cementoma, which is a subgroup of cemento-osseous changes. You can see reactive sclerotic changes, which are normally a reaction on inflammatic changes in the bone. And here we are with our root rest, and you can exactly see some kind of root filling material here inside. That's why it's really important, especially when you don't know the patient. When you make a panoramic radiograph, it is possible that you oversee small root rests, because panoramic radiographs only depict such a layer of bone, and it could be that small root rests are overseen in panoramic radiographs. So to evaluate a bone volume, especially with regard to these kind of changes, it's much better to acquire conium CT. You all know root rests. Other bone changes you can see here. I made a series of kind of sagittal images just for give you some alternate views to these typical transections. And what you see here is are not root rests. These are socket preservations, and you see that they can look very similar to root rests. So if you don't know exactly if there are any socket preservations, just ask the patient, or just figure out if you can figure this information out from the colleague who has done it before. So it might be really critical to differentiate between socket preservation and root rests. And here, once again, you see here this kind of material which was brought in here as well, and here as well. So this is all material, this is no root rest, and you can see it could be very critical to figure out if it is a bone, if it is a root rest or not. This is a patient with fluid and cemento-osseous dysplasia. What you see here is a large change here in the right lower jaw, just respecting the outer layer of the bone, a large change with some kind of hypodense material which is propagating here in the bone, expanding the bone a little bit. You can see, especially here, very well, some kind of expansion. And in a later on stage of this pathologic change, all this kind of hypodense material, which is hypodense due to the fibroblasts which are inside here, is remodeled into cementous material or cement material, which you can see here around this premolar, but here around you can see anyway the fibroblastic change. So all these teeth are vital. There's no change in the teeth. There's no problem, no pain. The patient has no pathologic sensation. But you can imagine that these kind of changes in the bone are not really predictable with regard to their biomechanic characteristics. Here, the next two here, you see a different stage with regard or in comparison to these two. So just remember that there are a lot of cemento-osseous changes, especially in the lower jaw. And another case here, let's say cementoma. And once again, the typical question which is asked with regard to the preparation prior to an implantation is, can I insert an implant there or not? I can only tell you that I wouldn't recommend this region for implant insertion, because you don't know what you will expect here. Somebody is saying to me that it would be nicer to just put all the material out and put some let's say bone augmentation material there, or bone reposition material. So you can imagine if this will run or not. I don't know, I only can tell you this is a situation where I won't recommend to put an implant in there. And another one, a smaller lesion, which could also be displaced compact bone, or in a similar shape, could also be a bone scar. There are a lot of lesions like that, so just check out how large they are, and if you can avoid to put the implants inside of these kind of lesions. And here, once again, very small changes. Could be reactive sclerosis as well, could be dislocated compact bone. From the radiological pattern, we don't know, so we only can say, yeah, we have to figure out if you really want to put some implants in there. And here we have a pattern which I want to show you. I wanted to show you that you can see that in detail. This is a patient with some fractured roots here and some really large periapical inflammation here. And what you can see here is a reactive bone change here. And for remembering that, I will show you immediately the other side of the lower jaw. So just compare this side with the normal side. Okay, so this is the normal side of the lower jaw, the right-hand side. And once again, the changed left-hand side, and you see that we see a lot of reactive bone changes. All this hyperdense structures here is reactive bone change. You see that the mandibular canal is, yeah, let's say, stressed by the bony changes. You see it much darker than before because the contrast between this dense area and the dark canal structure is much higher than in comparison with the other side. Once again, here we have, at least here we have normal cancellous bone, here normal cancellous bone, no sclerosis, and once again here a lot of sclerosis. So even there, you have to know that sclerotic bone changes are not a big problem. Sclerotic bone changes are only a sign of at least the impact of more minerals into the bony pattern as a reaction on, let's say, this inflammation. Okay? So reactive sclerosis, very typical in case of any kind of periapical or periodontal bone changes. Here you can see as well here periodontal bone change and a very small reactive bone pattern. And finally, we look out for some, yeah, let's say problems due to implant placement and some postoperative problems prior to implant placement. And both of the cases are at least severe ones. So we check out for the penetration of the mandibular canal. You all can imagine that there hasn't been, or there mustn't be, kind of a situation like that. The implants can penetrate the mandibular canal, but they don't have to. And the patient can have kind of dysesthesia or, yeah, change of sensation, because if the implant is, let's say, screwed onto the roof of a mandibular canal, there could be at least an edema in the tissue of the mandibular canal, which raises the pressure on the swamp cells of the alveolar nerve, which leads to at least problems with the sensation, and that means implants don't have to penetrate the mandibular canal. It can always cause problems in the patient. more or less you can lose augmentation material, and this is very critical with regard to external sinus lift and external sinus floor augmentation, and we will look at one of the cases. And that's why I tell you, please take care of any kind and any sign of acute sinusitis before going into action in terms of making any sinus floor augmentation. Okay, here we are with the both implants in the lower right mandible, and what you can see is a very typical situation when the implants are penetrated through the mandibular canal. The patient told me that once the implants were inserted, she never felt anything on this side, so which is really clear when you see that the complete lumen of the mandibular canal is obstructed by both implants, and that means that all the neural sensations are blocked here, and there's no further information delivered to the brain. So very clear. You all know these kind of figures. Let's say a more severe case is this one, and I remember that she came last year just some hours prior to the planned implantation. And some weeks before, the colleague put some augmentation material in the sinus floor, and what you can see here in the sagittal view of the right maxillary sinus is, let's say, some kind of heterogeneous structures of this augmentation material. You see some reaction here in the right maxillary sinus, but we will check out now for the right maxillary sinus, and you see here that there are particles of this augmentation material distributed through the whole sinus. The sinus is at least almost completely filled with fluid. I don't know exactly, but the patient told me that it was very thick fluid, and she had a longer history on maxillary sinusitis. So due to this acute sinusitis, the whole augmentation material was lost, and even some portions are here in the front, and another portion of the augmentation material is here near the physiological ostium of the maxillary sinus, so that even the normally drainage way of the maxillary sinus was blocked or obstructed, so that the process got more severe and severe, and finally the whole implant planning was thrown away. So I met her some weeks ago, so the situation in the maxillary sinus here is not much better now, and I only can tell you that please take care of patients with acute maxillary sinusitis or even severe chronic maxillary sinusitis before you enter the maxillary sinus for augmentation. So let's sum up all these information. What you can do, what you have to do is acquire appropriate volumes with adapted exposition parameters. Think about the volume you need for your patients, and think about the exposition parameters due to the constitution, if the machine allows you any kind of change. Use splints or guides with some reference objects. Just think about the implant axis, which can be seen in cylindrical shapes, but which are impossible to see in metal balls. So please use simple guides out of some plastics, which are very easy to fabricate for your CBCT acquisition. If there is any planned external sinus lift, I just repeated it 3 or 4 times, please acquire the upper jaw and a complete maxillary sinus with the physiological foramen of the sinus, so that you can control the complete volume and that you are very sure what you will deal with in the future in your planned operation. If you plan implants in the lower jaw, visualize the canal and perform some measurements. It's really clear. You have to do it as well in the upper jaw and make some proper reports. Make scout views like you've seen before, and in addition some separate transections, and save these images. So you don't need to open the whole data set when you talk again with your patients. Just make some scout views so that you know, okay, the data is from, let's say, the upper right jaw or lower left jaw, and in addition save some separate transections so that you can see your measurements in full screen view. What you don't do, or what you have to avoid, is the use of inappropriate data sets for measurements, especially when the patient moved while the acquisition was made. So just check for patient movement in data sets. You can easily observe that in the frontal teeth area, or if you see some double contours of the bone. So please check out for these kind of patient movements. Avoid any kind of severe metal artifacts which is striking through the bone. It could let's say, cover any kind of pathologic changes. Please wonder how to position the patient in the machine that all the metal artifacts due to crowns or any other restorations will travel in the occlusal area. Don't perform oblique measurements. That means, especially in the transections, look that the transection is parallel to your implant axis. If you don't rotate the volume for exact position, you will perform so-called oblique measurements, which will be in most of the cases too long, so that you overestimate your proper bone volume. Do not underestimate the pathologic bone changes I showed you, cementosseous changes, or even incomplete osseous consolidations, because these can be signs of some metabolic problems. These can be signs of improper bone biomechanic characteristics. So just check out for these osseous consolidations. And finally, and when we are talking about CBCT, I have to do this at least one time: do not overestimate the information on your 2D imaging or your clinical impression when you compare it with your CBCT results. So please be aware that any kind of information you generate out of a panoramic image is at least more or less not the same in value when you compare it to your cone CT data set. I have to thank you for your attention, and finally I only show this this kind of information to you, that we do a lot of individual teaching, group teaching. We are available for reading services, second opinion, and I hope that one day we can help you as well. So thank you once again, and see you next time here in the webinars. Thank you.
Thank you, Dr. Schulze. And we probably stay in the call, because I have 2 questions coming up from the audience. I can read them because I don't understand them. I'm not a dentist. So, on cases of lack of mandibular bone in height and volume, would you consider a creatal augmentation? If so, with what material?
In case of lack of bone, I would consider let's say, a mix of augmentation material, which can be like bio-os or something like that, so not human, even industrial preparation, and a mix with own bone, that means autologous bone from the patient. That would be my recommendation. From the last 10 years, what I've seen is that in most of the cases, a mix of the patient's own bone and additional augmentation material out of the box is, from my point of view, the best solution.
Okay. And the second question was, on the case of sclerotic bone, would you recommend in favor or against the implant placement?
In case of sclerotic bone, I think this is not a big problem, because sclerotic changes are only, let's say, a reaction on inflammation. If the origin of the inflammation is gone, let's say due to an extraction and further exfoliation of the area, there is at least no danger that the biomechanic properties of the bone are really changed. This is just let's say the flooding of mineral salts into this area to make a barrier against the inflammation. If the origin of inflammation is gone, there is no, from my point of view, I see no problem to put an implant in there.
Mm-hmm. Okay, and I think the last question for today is, wouldn't it affect the vascular properties and therefore healing of the site? I think it's referring also to the sclerotic bone.
Just can you remember? I can't read the question.
Wait a second. I post it here
wouldn't it affect? I see. I go to the chat window. Chat. Wouldn't it affect the vascular properties and therefore healing of the site? I don't understand the question correctly. I think what would affect the vascular properties and therefore the healing? Maybe the sclerotic changes. Yeah, that's a nice question. But as far as I can say, that when you check out bone changes in MRI, you can see a lot of vascular changes. You can see edema, you can see change of the normal marrow pattern, and so if you would see any kind of these bone changes in MRI, I think a lot of people would avoid placing implants inside the bone because they didn't know what will happen there. And from my point of view, that if sclerosis is a normal reaction of the bone with regard to inflammation, and the origin of the inflammation is gone, I don't see, in case of typical, let's say, sclerotic changes due to, let's say, periapical changes, I don't see any obstacle for an implant insertion. So I don't think that this can be compared to a typical osteomyelitis or something like that. So only small changes can be, there would be no obstacle for implant insertion. And there's another question I see. I
think one left, yeah, exactly. How we can do the difference between an artifact or the translucency of the implant failure, or it's always a critical thing in 3D tomography, right? And
what do you mean with difference between artifact translucency? Yeah, do you mean that the metal artifact is? Yeah, I understand. I think what is meant is the artifact around an implant.
Yes.
Right now, we can say that the CBCT machines let's say, become more and more better with regard to the depiction of, let's say, one single implant. So today it is possible to view all the bone around the implant, so these kind of artifacts can be avoided in the future. The problem will occur again when at least two implants are side by side put inside together. So it could be that there is again artifacts, and to overcome this situation, I only can recommend to make some intraoral radiographs to control that. But this, as long as we observe these kind of artifacts, there will be no solution for this question. Yeah. Well, that means with one implant, I can look around, okay, but if there are two or more implants side by side, there will be, in all cases, there will be kind of signal loss, and that means there is a metal artifact. Okay?
Okay, thank you very much. Thank you very much also for the to the participants to that questions and answers here. So I started at the beginning that we have recorded this webinar, so it will be available soon on the web pages. And you will also, all audience will get a link automatically by email. And if there are any questions regarding the software that Professor Schulze used for the implant planning and to show this, the on-demand software, I'll be happy to answer your questions on that. So my email address is tobias.bauer@kavo.com. And yeah, if there are any questions to Professor Schulze himself, you can also pass them through me. So I will thank you for this webinar. Thank you, Dr. Schulze, and yeah, have a nice rest of the day.
Thank you. Bye-bye.
Bye-bye.